Welcome to the lecture class series. So hi, I am Dr. Priya Dharshini, Assistant Professor from the Department of Oral Medicine and Radiology. So today we are going to talk about an interesting topic which is on the examination of lymph nodes. It is a quite interesting topic from the examiner's point of view because it is mostly asked in the Viva point of view. So let's get into the topic. What exactly a lymph node is? So lymph node consists of a lymphatic system, and the major organs which comes under the lymphatic system includes the thymus, tonsils, lymphoid organ and the spleen. So lymph nodes are the accumulation of lymphoid tissue along the course of the lymphatic vessels. So in our human body, the fact is that we have around 600 lymph nodes, so which play the major role in filtering the lymph, which acts and circulates throughout the body. So what is the primary function? So the primary function deals with the antigen in the form of organisms, or either in the form of particulate material or also in the form of soluble antigens. So whenever we want to discuss something on the examination, we should thoroughly know about the anatomical part of the particular organ. So we will discuss on the anatomy of the lymph node. So basically a typical lymph node will be in a few millimeter, that is exactly a shape of a kidney bean. So which consists of a hilus in the concave surface through which a small artery passes, and vein exits through the surface of the concave portion and where the efferent vessel also exits. So the opposite of the concave surface is the convex surface where the afferent lymphatic vessels enter. So basically the lymph nodes are distributed as clusters in places. In example, in the neck, in the axillary region and the groin, where the afferent vessels can drain defined regions of the body. So here we are going to talk only about the cervical lymph nodes, that is the lymph nodes which are present in the head and neck region and not on the lymph nodes which are in the other parts of the body. So we'll know the fate of a lymphoid organ. So here comes the role of the physiology of a lymph node. So lymph node basically consists of two lymphocytes that we actually know, which are the T lymphocytes and the B lymphocytes. So the T lymphocytes, B lymphocytes along with the antigen presenting cells, that is the macrophages, which is also known as the dendritic cells, which enters the human body. So when it enters, that is the T lymphocytes, B lymphocytes and the antigen presenting macrophages, that is the dendritic cells, the tissue lymph also enters along with the lymphoid tissue. So where the afferent vessels usually produce a space for the tissue lymph to go into it. So when it usually happens, there will be a coalesce, which means there will be a joining of all these tissues and it will drain to an efferent lymphatic vessel. So it passes, which means it enters, it coalesces and then it exits. So this is how a lymph fluid joins, starts and then enters through a lymphoid organ. So the particulate matter is usually phagocytosed. So what is exactly the word phagocytose means? It just means eating. So the particulate matter is phagocytosed by the macrophages lining the lymphatic channels. Once phagocytosed, which means once the eating is being done, the foreign antigens become bound to the surface of the macrophages. These foreign antigen bound to the macrophages and other cell surface receptor activates the T helper macrophages. Here the T helper macrophages play an important role in the lymphatic system. So how does it play is that these lymphocytes in turn activates the B lymphocytes. So the first T lymphocytes gets activated, in turn it activates the B lymphocytes and alternatively it directly activates the memory B lymphocytes. So the role of memory B lymphocytes is very, very important. Why? Because whenever a disease is being in the human body or which is being noted, these memory B lymphocytes usually, as the name suggests, it has a memory of what the disease has been infected with the patient. So next time if the same disease gets infected, then this type of specific macrophages get into the play and then it destroys the disease. So this is how a usual lymphatic system works. So as we all know, the T lymphocytes activates the B lymphocytes and the B lymphocyte in turn activates the memory B lymphocytes. So the B and T lymphocytes proliferate and they create a pool of lymphocytes. So we have actually three types of lymphocytes, that is the B, T and the memory B. So they have the ability to recognize and bind to the inciting foreign particles. So these foreign particles are the disease encountered by the patients. So in addition to the activated T lymphocytes and the macrophages, we also have certain cellular signals, that is the cytokines, that induce the leukocyte chemotaxis and increase the vascular permeability. So whenever there is an infection, the first role or the first one to come into the action will be the lymph nodes. So how does a lymph node look, or how does an histology of a lymph node will be seen in a microscope? So basically it has two zones, a darkly stained cortex and a lightly stained medulla. So we're going to concentrate on the cortex and the medulla. So first we will think on the cortex. So what is the cortex? It is a darkly stained cortex which is the bounding, the outer layer, the peripheral shell of the lymph node. So the several rounded areas of lymphatic follicles will be usually seen in the cortex. So there will be a germinal center which contains the dividing B lymphocytes. The parafollicular areas contains the T lymphocytes. So this is the exact structure of a cortex. Then we will go on to the medulla. So medulla is a lightly stained structure. The lymphocytes are arranged less densely in the place of medulla. So sinusoids are present for the free flow of the lymph. So whenever the lymph is getting obstructed, then there will be series of issues such as lymphadenitis, lymphadenopathy. So which will be discussed in the upcoming portions. So we have had an idea about the introduction, anatomy, physiology and the histology of a lymph node. Now we will move on to the lymphatic drainage of the head and neck. So as we all know, head and neck is basically a very important structure in the whole body. It has numerous vessels, arteries, veins and the lymphatic vessels. So each and every organ gets drained into, if there is a disease, it gets drained into a particular lymph node. So we have to have a schematic representation of the lymphatic drainage of the head and neck. So we have two classifications in a lymph node. First we have to concentrate on the anatomical classification, and the other classification will be given by the AGCC, that is American Joint Committee on Cancer, for the surgical dissection of the lymph nodes. So basically we have two classification. One will be the anatomical classification and the other will be the American Joint Committee of Cancer classification for the surgical dissection. First we will look on to the anatomical classification. So we can have, in anatomical classification we have two subgroups. One will be the horizontal lymph node group and other will be the vertical lymph node group. So we will link on to the horizontal. Since it is, the term defines horizontal, it goes in the horizontal basis. We will start from the submental, which is near the chin. We go on to the submandibular. Then we will go on to the parotid, which is evident near the ear, and will be the pre-auricular, which is also near the tragus of the ear. Then will be the post-auricular, which is behind the ears. Then we will have occipital. Occipital is behind the head in the last portion. So we have 5 groups in the horizontal: submental, submandibular, parotid, pre-auricular, post-auricular, and the last will be the occipital. Then we will move on to the vertical. So the vertical basically consists on the AGCC classification. It has been further divided into central and lateral. So first we will see on to the central lymph nodes. The central lymph nodes will be the pretracheal, pleryngeal and paratracheal. And the lateral lymph nodes will be jugulo-digastric and jugulo-omohyoid. So it will be seen in this portion. The horizontal will be from here, from submental till the ear, and the vertical will start from here till the end of the superior mediastinal group. So this is the anatomical classification. So basically, to revisit, we are going to classify into two types, that will be the horizontal and the vertical group. And horizontal will be classifying in sections in the horizontal portion and vertical from this portion. So we have an idea on the anatomical classification of the lymph nodes. If there is an anatomical classification for a lymph node, then why there is a need for another classification? Here comes the question. So the anatomical classification is basically for the clinical examination of the patients. So whenever we see a patient and we diagnose with a disease, we are going to say which lymph node is being infected. But as a surgeon, in the point of surgical dissection, we should have a classification. Here comes the role of the American Joint Committee on the Cancer. They have given a specific classification which is based on the levels. So level 1A will be the submental and the level 1B will be submandibular. So level 2, 3, 4 will consist of the jugular component. That is, level 2 will be upper jugular, level 3 will be the middle jugular, and the level 4 will be the lower jugular. So we have concentrated on level 1, level 2, level 3 and level 4. Then we will go on to the level 5, which is the posterior triangle group, which is behind the ear. And level 5 is the posterior triangle group, and level 6 will be the anterior compartment, which is below the neck region. This is the level 6 group, and the last one is the level 7, which is the superior mediastinal group. So again we will have a discussion on this. We have 7. First one will be the level 1, level 1A, which is submental. Level 1B will be the submandibular. Level 2, 3, 4 will be the jugular compartment, which is the upper, middle and the lower. Level 5 will be the posterior triangle. Level 6 will be the anterior compartment, and level 7 will be the superior mediastinal group. So this American Joint Committee classification is basically for the surgeons for the dissection of the lymph nodes. So we have an idea of the classification of the lymph node. Now we will be dealing with the examination of each and every lymph node and its applied aspect. So before moving on to the examination part, there usually 2 steps in an examination. Whatever examination we take, if we take an examination of a lymph node, examination of lump, examination of a TMJ, we should always have 2 factors. The one will be the inspection part and the other will be the palpation part. So first we'll be talking about inspection part. As the name suggests, inspection, we just only see the patient and say what is being infected. We don't palpate or we don't use our fingers to touch the patient and tell the diagnosis. That comes under inspection. Whereas palpation is that first we will confirm the inspectory findings and then palpate and arrive at the diagnosis. So there are 2 parts in an examination. First will be the inspection, second will be the palpation. So we will, while dealing with the inspection part, we have to think on the 3 basic concepts. The first will be the position of a lymph node, the number of the lymph node and the pressure effect. So moving on to the position of lymph nodes, we are going to talk about the horizontal group of classification, which would be submental, submandibular, preauricular, postauricular and the occipital type of lymph nodes. So this position exactly determines what type of disease the patient has and where it is going to get infiltrated. So this is a very important aspect in the inspectory part of lymph node examination. Then we are going to move on to the number. So why does this number plays a role? Because in certain case of diseases like Hodgkin's lymphoma or lymphatic leukemia or lymphosarcoma, this number always plays a role. So whether it is bilateral or unilateral or the lymph node is mated or not mated, all this plays an important role in case of number. Then we are going to see on the pressure effect. So pressure effect is that when there is some swelling or a venous engorgement, when it has been infiltrated with some or the other structure, then of the face and the neck, then will be swollen. So when it is swollen, which means it denotes that there is some more additional infection prior to the lymph node infiltration. So these 3 criteria should be noted in case of inspectory part of the lymph node examination, which is the position, number and the pressure effect. Now we will be moving on to the palpation. So before moving on to the palpation, I would like to give a keynote that whenever we do a palpation, our inspectory findings should be confirmed, which means all the inspectory findings should be reliable and it should be appropriate to the palpatory findings. There should be no contradiction between inspectory and the palpatory findings. So we move on to the palpatory findings. So we will be saying that all inspectory findings are confirmed. Then we'll move on to the palpation. So how we are going to do a palpation? Basically, for the node to be examined, you should slightly tilt the head and then start palpating, though it is an horizontal classification or a AGC classification. So we'll just tightly ask the patient to tilt the head. We have to stand behind the patient. So that is how an examination of lymph node should be done. The patient will be sit upright and we, the examiner, should stand behind the patient and then we'll start palpating for the lymph node. And the palpation of the lymph node also go only by the order. We can't get it exchanged. It will start from submental, submandibular, preauricular, postauricular and the occipital. When it comes to level 1 to 7, it should go from 1, 2, 3, which is the compartments, 4, 5, 6 and the last will be the superior mediastinal group. So this is how the examination should be done. And important part of this palpation is that we have to use the palmar aspect of the fingers. Now we can't use any fingers, we can't do only a single finger and only the palmar aspect of the finger to know the pressure or how the node is, how is the fixity to the underlying structures. So when we are palpating for a lymph node, we have to concentrate on 2 things. One will be how many lymph nodes we are able to palpate and second will be whether it is mobile or firm. So what is the difference between mobile or firm? When it is a mobile lymph node, which means it is in the inflammatory part, it is in the benign part, so we can rule out the malignant condition. When it is a malignant condition, for example, if it is an Hodgkin's lymphoma or a lymphatic leukemia, which means the lymph node will be fixed to the underlying structure. The palpation will not be easily feel by us. So there will be there will be a rigid structure which is evident, which says that okay, this is going to the stage of malignancy. It is not in the benign stage. So this way we can easily distinguish between the benign part and the malignant part. Whenever the tissue is being fixed or the lymph node is being fixed, then it is usually comes on the malignant part of the disease condition. Palpation of the lymph nodes of the neck commonly begins from the superior nodes and work down to the supraclavicular lymph nodes. So these are the 2 portions how we start, which has been discussed earlier. Always follow the rule. We start from the first lymph node, then we end with the last lymph node. Suppose here comes the question, if the patient is not infiltrated with either of the lymph node, then focus on the lymph node or the part which has been infected. For example, if the patient has a cancer in the tongue portion or the patient has a cancer in the buccal mucosa portion, then the most common lymph node which has been affected in the buccal mucosa will be the submandibular lymph node. So our aim is to know whether the submandibular lymph node is being infiltrated. But we also have to remember that in that case we can't like neglect submental. So that is why I always say start from the first. Examine all the lymph nodes from the submental to the superior mediastinal. So we'll have a clear examination. So we'll start from the first lymph node. So which is the submental lymph node. As we all know, submental, it is in the mental region of the chin. It is here. So it lies on the myloid muscle in the submental triangle. We all know we have different triangles in the head and neck, which is the submental triangle, anterior triangle, posterior triangle. All these triangles have, and all these triangles have separate lymph nodes. So submental lymph node is basically in the submental triangle. So it usually drains in the tip of the tongue. So the tip of the tongue usually drains in the submental lymph node. So next we will moving on to the submandibular lymph node. As I have discussed earlier, this lies in the submandibular triangle, which is located here. So submental is located below the chin region and submandibular is located in this region. So it drains the lateral part of the lower lip, upper lip, cheek. Basically the cheek. The cheek usually drains in the submandibular region, and the gums, teeth, medial canter, soft palate, most of the anatomical structures which is present in the oral cavity usually drain in the submandibular lymph node. So the basic two lymph nodes which plays an important role in head and neck examination will be the submental and the submandibular lymph nodes. Then we are going to see about the parotid nodes. So the role of parotid nodes comes when the parotid gland is being affected, which is we have a salivary gland tumor, when it be a benign salivary gland tumor or a malignant salivary gland tumor, the parotid nodes play an important role. So they lie partly in the superficial fascia of the parotid gland. Basically the lymph node is located in the superficial fascia. If suppose the lymph node is being palpated in the deep fascia, which means it is being fixed to the underlying structure, which means it is in malignant stage of the salivary gland tumor. So basically the parotid node drains into the parotid gland, which is the major salivary gland, the upper part of the cheek, temple, side of the scalp, lateral surface of the axilla and the middle ear. So to concentrate even more, I would say that parotid node drains into the parotid gland, which is for easy understanding. Next we'll move on to the posterior auricular nodes. So the posterior auricular nodes also known as mastoid nodes. Why mastoid? Because here is the mastoid region. So the posterior auricular nodes is usually known as mastoid nodes. So they lie on the mastoid process which is located behind the ear. So usually these nodes drain is that when there is an infection in the scalp region, when there is an infection or the psoriasis in the scalp, then the first node to be infected will be the mastoid process. That is the mastoid nodes which is located in the mastoid process. And sometimes the posterior surface of the pinna, because the pinna, the ear is being located here, the pinna is being commonly affected, then the drainage will be to the mastoid nodes. And efferent drains into the posterior superior group of the deep cervical nodes is also located. So the posterior auricular nodes basically is for the mastoid group. Then we see the occipital nodes. Occipital nodes, as we all know, it lies in the apex of the posterior triangle, which means the behind the head. So efferent drain into the supraclavicular members of the posterior inferior group of the deep cervical nodes. So when you palpate for the occipital nodes, it's usually the backside of the head and neck region. Then we have completed all the horizontal group, that is the submental, submandibular, posterior auricular and the occipital. Now we will move on to the AGCC classification. So in this AGCC classification also, since I have mentioned earlier, it is a surgical dissection classification. All the submental, submandibular, preauricular, postauricular groups, their anatomy will be the same. Only the vertical group, which I am going to discuss here, that is the anterior cervical group and the superficial cervical group comes in the vertical part. So the anterior cervical nodes, as the name mentioned, it is located into the anterior jugular vein, which is an important structure in the dissection of any tumor. We should always have an idea of preserving the internal jugular vein, anterior jugular vein, and in case if it is needed, then we can put a ligation in the external carotid artery. So here comes the role of AGCC classification for surgical dissection. Then we'll be talking about the superficial cervical nodes, which lies along the external jugular vein. So the external jugular vein plays a major role in case of superficial cervical nodes. Then we'll be seeing about the lateral cervical nodes, which is near to the superficial cervical nodes. It has been divided into two groups. So we have two classifications here. One will be the superficial group, another will be the deep group. So the superficial group lies along the external jugular vein and it drains into the internal jugular vein. Whereas the deep group consists of three important structures or three important chains. That is the internal jugular vein, spinal accessory and the transverse cervical. So to my point of view, we should always concentrate on the horizontal group, but at times in case of later stages of any malignancy, all these vertical group of lymph nodes come into play. So we'll move on to the next 2 points, that is the internal jugular vein and the spinal axillary chain. So the internal jugular vein, as we all know, it lies anterior, lateral and the posterior to the internal jugular vein. So internal jugular lymph node is usually located anterior, posterior and lateral to the internal jugular vein, and the lower jugular groups drain into the larynx, thyroid and the cervical esophagus. So next we are moving on to the spinal axillary chain. So spinal axillary chain, as the name mentioned, everything is based on the anatomical classification. It moves along the spinal axillary nerve. So spinal axillary nerve, spinal axillary chain. So the terms are similar to that of the anatomical classification. Then the last one will be the transverse cervical chain, that is the supraclavicular lymph nodes. So when we are palpating for the transverse cervical chain, it lies horizontally along the transverse cervical vessels in the lower part of the posterior triangle. So we have seen that it is the last portion, that is the superior mediastinal portion, is where the region we palpate for the transverse cervical chain. So these medial nodes of the group are also called as scalene nodes, which is an important node. Usually we see during the surgical dissection, which is the scalene nodes. So afferent to those nodes are come from the axillary chain, and this is important for certain structures like breast, lung, stomach, colon, ovary and testes. So these are the vertical group of AGC classification. So to have a recap, that we have classified a lymph node based on anatomically and AGC, and we have understood the anatomy of each lymph node and how to palpate them. So whenever there is a lymph node, we should know the applied aspect of a lymph node, why it is exactly needed to examine a lymph node. So it is the first line of defense by knowing which disease is being affected. So basically 2 types of diseases can be identified from a lymph node enlargement. One will be the lymphadenopathy and other will be the lymphadenitis. There is a small difference between lymphadenopathy and lymphadenitis. Itis usually means inflammation, which means there is an inflammation of a lymph node. So lymphadenitis is an infection of the lymph node. So whenever a lymph node is being affected, the first diagnosis will be lymphadenitis. So since they are the basic part of the immune system, they will be the first one to be getting attacked. So what is the difference between lymphadenopathy? So lymphadenopathy is a normal response of the lymph nodes to an infection. So once we get an infection, how will be our response? These lymphocytes, that is the T lymphocytes, B lymphocytes and the memory B T lymphocytes play a role. They give a response to the foreign body or a foreign antigen in the case of lymphadenopathy. So these are the 2 applied aspects of a lymph node. So to conclude, I would say that always examination of a lymph node is a typical in a clinical examination, because it is the first line of defense in an immune system and it tells what exactly the disease condition is. So when you have a good practical clinical chairside examination, then it will be easy for us to evaluate further in the using radiographs. So this comes to the end of the discussion on examination of lymph nodes. I'll meet you guys in another lecture.